Welcome to the Meth and Fentanyl Crisis Panel discussion. I'm Lauren Meister, council member for the City of West Hollywood, and I'll be one of your moderators this evening. This panel is also being recorded and will be available for future viewing on the city's YouTube channel. Attendees, if you have a question, please include them in the chat box, and based on timing, we'll see how many questions we can get to. We have a pretty action-packed discussion guide. So the CDC reported that in 2021, more than 71,000 people died from synthetic opioid-related drug overdose in the United States. Annually, this number continues to increase every year. This is a problem that affects all of our communities and people from all walks of life. This conversation is intended to increase community awareness on the dangers of these drugs, the impacts to the community, and the resources available. I want to first thank our panel guests, co-moderator, and attendees for tuning in tonight. At this time, I'd like to introduce City of Beverly Hills Council member, Dr. Sharona Nazarian. She is passionate about this subject, works in the clinical psychology field, and serves as a LA County Commissioner for Alcohol and Other Drugs. Take it away, Dr. Nazarian.
All right, well, thank you so much. Thank you for this gracious invitation. And I want to extend my heartfelt appreciation to Councilmember Meister for including me in this pivotal discussion. As elected representatives, it's important for us to recognize and acknowledge that the challenges that we're facing by our communities transcend city borders. That's why it's crucial for us to forge partnerships and collaborate towards seeking constructive resolutions for the betterment of our collective community. And tonight I have the great honor of introducing our esteemed panel of experts. You guys are really in for a treat, and this is not in any particular order. First off, Sam Quinones is a journalist, storyteller, former LA Times reporter, and author of 4 acclaimed books of narrative nonfiction. His most recent book is The Least of Us, True Tales of America and Hope in the Time of Fentanyl and Meth, released in 2021. The book follows his 2015 release, Dreamland, The True Tale of America's Opioid Epidemic. And next we have Dr. Itai Danovich. He is an MD, MBA, and is professor and chair of the Department of Psychiatry and Behavioral Neuroscience at Cedars-Sinai Medical Center. Dr. Danovich's clinical practice and research focuses on substance use disorders, as well as the integration of medical and mental health services. Dr. Danovich is the author of over 80 articles and book chapters and co-editor of 2 books on substance use disorders. He serves as a governor-appointed state commissioner on the California Mental Health Services Commission. Next, we have Dr. Gary Tsai. Dr. Tsai is an MD, is a physician executive who is the director of the Substance Abuse Prevention and Control, a division of the Los Angeles County Department of Public Health. In his role, he oversees a full spectrum of substance use prevention, harm reduction, and treatment services for the 10 million residents of Los Angeles County. Dr. Tsai also serves on the board of directors of NAMI California and is a board-certified physician in both general psychiatry and addiction medicine. And finally, we have Bruce Boardman. He is the Chief Executive Officer for Social Mode Recovery Systems. SMRS is a nonprofit organization that provides behavioral health services to at least 10 locations in Los Angeles County for those lives have become unmanageable due to alcohol and other drug use, and or whose mental health issues are interfering with leading productive lives. With over 30 years of service to SMRS, he has been responsible for the development and expansion of the organization. Among his peers, he is recognized as a pioneer in the field of co-occurring disorder treatments. We are delighted to have you all join us here tonight. And it's a privilege for me to have worked with several of you on the panel in various capacities. And we look forward to really engaging in a timely and productive conversation with all of you. So with your permission, we'll kick it off. Meth and fentanyl are causing a major problem in the United States. And we really want this to be an open panel. Any of you could really step up at any time with the questions that we're putting out. So can you describe each of these drugs and its effects on people? What makes these drugs so addictive?
Well, I'm happy to take a first crack, at this, though I know others can have a lot to say about it. And first, let me just thank you both, council members, for partnering together as we all need to do to address these problems. Really, really appreciate your attention and focus to this important subject. Methamphetamine and fentanyl are two very different drugs that have very distinct effects and have some similarities. The distinctions are that methamphetamine is a stimulant. It stimulates the brain and the body, whereas fentanyl is a type of opioid. Opioids calm the brain and calm the body. They attenuate pain. They make pain go down. They make anxiety go down. They make everything calmed. Actually, they keep on depressing the effect of the brain until they can stop breathing altogether and other vital functions. So these are two very different drugs. What they have in common is they both can produce a sense of well-being. They both produce a escape or disconnection from where you are. They both produce pleasurable experiences, and they're both highly, highly reinforcing. They both stimulate a part of the brain that is involved in goal-directed behavior and can really commandeer that part of the brain. So these are addictive drugs, but your other question is, what's the substances and what makes them addictive? Addiction is a combination of potentially addictive drug and a susceptible brain. Not everybody who takes a drug becomes addicted to it. And that's because the vulnerabilities to developing addiction have to do with genetic factors, psychological factors, and social factors that we can get more into as we discuss things. But that susceptibility has to do with a highly addictive substance and then an individual who's vulnerable for a whole host of reasons.
Great, thank you for that. So just a little follow-up on that. Do you think that the pandemic exacerbated the crisis of meth and fentanyl and the opioid crisis? And if so, can you elaborate in which ways?
Yeah, hi.
Go ahead, Gary.
No, go ahead, Bruce.
Well, I think one of the issues that it created was we've been treating methamphetamine addiction for many, many, many years. During the pandemic is when we started to see fentanyl as an adulterant in methamphetamine. But we had already started our work as far as being in this pandemic and having to do isolation and quarantine and things of that nature with the individuals who are coming into treatment. So now we're providing treatment services where prior to that, we were able to engage people and really work directly with them. And instead of doing that, we're providing isolation and things of that nature when they come into treatment. That's the first exposure that we had for individuals who are coming to treatment. It couldn't have happened at a worse time as far as the pandemic and fentanyl being introduced into methamphetamine. I don't think it could have happened at a worse time.
So thank you for that. In 2021, the total number of people in LA County who died due to accidental overdose was 2,741. And approximately 715 of these individuals were experiencing homelessness. On a regional level, can you describe the impacts of these drugs on the issues of homelessness?
Yeah, I can weigh in on this. Definitely, there's a connection. When you look at research, there's variable percentages in terms of the proportion of people experiencing homelessness who have substance use disorders. I mean, it can go anywhere from 30 to 80%. I would say that the key takeaway for me is there is a high prevalence of substance use disorders in people experiencing homelessness. And With an issue like homelessness that's as multifaceted as it is, I think it's really essential for us to be addressing as many of those variables as we possibly can. When we talk about things like whole person care, I mean, the idea is to try to address co-occurring conditions, whether they're physical health, mental health, substance use, or social drivers that we need to be addressing that we're not. There are a lot of opportunities with initiatives like CalAIM and enhanced care management in order to better do that. But I absolutely think that substance use disorders and how we address homelessness are tied, similar to how better addressing mental health issues, better addressing housing challenges are also levers that we need to be focusing on.
Can I say also, not necessarily about this question and specifically, but the last couple of questions as well. It seems to me the essence of the problem of methamphetamine and fentanyl is in the quantity of supply that is cascading into this country out from Mexico. These drugs would not be a problem were that supply significantly reduced or virtually non-existent. What you also are finding that is I think, essential to understand about both fentanyl and methamphetamine is that they are coming in at extraordinary potency. And normally in the drug world, when you get a very potent drug and you're not clear where the next supply is going to come from, as a dealer, you cut it, so you dilute it. The problem is these drugs are coming in such staggering quantities at such high potency, and the quantities are not stopping. It's like it's not a wave, it's a new kind of high tide. And so what that means is that these drugs are not cut. They are rarely, the methamphetamine in particular is at extraordinary high potency. Probably no human brain in the history of methamphetamine has ever been exposed to the kind of potency that we're seeing come in routinely with methamphetamine from Mexico particularly in the last, I would say 10 years, into LA, certainly the last 10 years. And so to me, it feels like the problem with these drugs is not just that they are a stimulant and a depressant. It's that the quantities of them, the supplies of them, the potency, and the fact that on the street, because they're so potent, dealers don't have any reason to cut their dope. Meaning you were getting stuff coming straight out of the lab in Mexico onto the streets of LA. Normally in decades past, that dope would be cut and diluted, in other words. And now you're just not seeing that, nor are you seeing it in much of the rest of the country. And this is because dealers know that the supply is not going to end. They don't have to cut their dope anymore because they know that there's 4 or 5 sources within a few miles of them where they can get this stuff. And so what you get is extraordinary potency in unrelieved quantities. And to me, this is the essential thing that has changed with fentanyl and methamphetamine, particularly last several years. You did not see this with other drugs. The other drugs were not nearly as potent, and frequently they were also cut. Heroin was, for example, cocaine is another. So to me, it feels like this is what makes this a brand new situation. We have never seen the quantities and the potency. And in fact, I would say in the price drops too. The price of methamphetamine is at historic lows. They cover the country with methamphetamine and drop the price. It's an amazing idea to think that they were able to cover the country with meth and the price dropped by 90%. So this is why these drugs are so are posing new challenges and new issues for counties, for towns, tribes, et cetera, all across this country.
So you're saying that a lot of it is correlation with the potency, the increased level of addiction is going up, and the supply. There's
it's absolutely, in my opinion, it's really very much a supply creating demand, not the other way around. If you go to Tucson and where I've been and talked to a number of people there, addicts, but also drug counselors and so on, you'll find that people are smoking in regards to fentanyl, smoking those pills that we're now seeing fentanyl come in counterfeit pills that look like Percocets and Adderall and Xanax and on and on and on, a bunch of different kinds. You're finding people smoking daily 20, 30, 50, sometimes 80 pills a day. What that means is their tolerance is staggering. It's so high. And getting people into treatment and wanting to leave the street because they're terrified of the withdrawals. They do not want to leave the street. They do not want to leave the dope because they're terrified. The withdrawals at that level are beastly, just devastating. And so but all of this again gets back to the supplies coming into our country, and the potency of those supplies. And I think this is really, you can take a look at what's going on in LA, other cities on the West Coast, but also in rural areas of the rest of the country and cities as well. And it all kind of corresponds to the tremendous supplies that are inundating our country, with both these synthetic drugs.
Sam, not only that, but one of the pieces that I've heard a lot from people that we work with is the half-life along with the potency. The half-life on methamphetamine is very long. People
Yes.
can use methamphetamine. They can do a bump of methamphetamine and it could last them all day. Now we've introduced fentanyl, which the half-life is very, very short, 15 minutes. Now we've introduced fentanyl into that supply of methamphetamine, which has changed the delivery of that drug now and
Right.
is requiring, it's kind of like when crack cocaine hit Los Angeles back in the 80s. Crack cocaine, there was many individuals using cocaine, but once people started smoking crack cocaine, the half-life with crack cocaine was so short that a person would become so addicted and use so much in a day that it created a lot of the problems that we have. And the same is what we're hearing from our participants in regards to methamphetamine that's mixed with fentanyl. Is
You know,
the half-life is much shorter and their requirement to use at a higher rate is much, much higher.
You know, it's interesting. That's what makes fentanyl such a great drug in the operating room, right?
Exactly.
It can take you in and out of anesthesia very quickly. I've had fentanyl when I had a heart attack 6 years ago now, and that was the benefit of it. The problem is on the street, it's a torment for users. It means you have to use now 6, 7, 8 times a day. I've heard as many as 8 times a day. You know, for users, it's a disaster. For the dealer, of course, it's a huge bonanza.
Exactly.
So let's switch gears a little bit. You know, the concept of dual diagnoses is coming up often, clearly in the context of methamphetamines and fentanyl use, and how it intersects with the use of issues of homelessness and individuals who are really forced to self-medicate. Can you speak to that, please?
About 95% of the individuals that come to treatment today are coming into treatment in an ASAM level of care of 3.5, which means through an assessment, they've identified as having an underlying mental health problem along with a substance use disorder. That didn't exist 5 years ago. So are we doing a better job of assessing? I think for one thing, we're doing a much better job of assessing individuals and getting them the care that they need. But I also believe that this pandemic and some of the trauma and other exposures that people have experienced through this pandemic has also created a new population of individuals that are coming to treatment.
So just if I can follow up, so for the doctors, is that what you're seeing?
Well, yeah, I would agree with what Bruce just said. For your audience, just dual diagnosis is actually a little bit of an outmoded term. It speaks to having both a substance use disorder, like addiction, and having a mental health disorder. And it's outmoded because historically we thought about these things as separate. And as a result, we developed separate treatment systems, a separate treatment system for substance use disorders and another treatment system for psychiatric problems and another treatment system for physical health problems. What we understand is in a given individual, these problems tend to co-occur. Medical health problems, substance use disorders, and mental health issues. And to effectively treat people, we have to integrate treatment and deliver care for all of these things together. It doesn't really work to separate them out. So it is absolutely true that the comorbidity or co-occurring disorders is much more the rule rather than the exception. And particularly when we're talking about people that have unstable housing, there is so much stress and so much trauma that invariably people begin, if they didn't begin with mental health disorders, they develop mental health disorders because of the trauma. And when you have severe and untreated mental health disorders, you need some kind of relief. And fentanyl and methamphetamine all provide different types of relief. So that's why they're so inextricably bound.
Now, I have a follow-up question to that, which is, you know, so a lot of individuals are trying to treat themselves, and they may not even realize or be aware that they need help. So how can we treat someone who is not willing to get treatment?
Ooh.
So this is one of the fundamental initiatives that we've launched this year, which is called Reaching the 95% Initiative within the Department of Public Health, Substance Abuse Prevention and Control. According to federal data, 95% of people who do not access services don't access services because they either don't want it or don't need it. This is the fundamental problem that behavioral health systems, substance use systems need to solve in order to ensure that people who need the services have them. How are we doing that? I think there are different strategies that we need to employ because no single answer is going to, be the solution. Better outreach and engagement's one aspect of that. An important component of that, I would say, is harm reduction services. That's something that we've invested more than 5 times the amount of funding in over the last 3 years. And one of the reasons why that's important is because harm reduction services engage people who oftentimes are not ready for treatment. Many of the people served in harm reduction agencies are not concurrently in treatment. They are people who use drugs, who are interested in those services for other reasons, right? And it's been demonstrated to reduce comorbidities, such as transmission of infectious diseases, HIV, hepatitis, et cetera. It's been shown to reduce overdoses with no impact on public safety, and has been shown to increase access to needed services. And so, that's one arm of the Reaching 95% initiative. The other arm is lowering any barriers we have to the treatment system. Many treatment agencies now require abstinence for someone to be admitted into substance use treatment. That's something that we are looking to modify because it represents a barrier that's too high for many people who are struggling with substance use disorders. And it's something that will take time to change because I think a lot of people think about their recovery as if I can't stop using for any period of time, that means I'm not ready for treatment. And we don't think that that's true, right? We think that people can be ready for treatment and also not yet be ready to stop their use completely. And I think that nuance is something that we're looking to navigate through the Reaching 95% initiative.
That's a very new concept. So
Can I say one thing about that though? This is the problem that we're facing as a country, and that is that when you wait for people to have some kind of readiness on the street, that used to be an approach that was years ago when the drugs were not deadly fentanyl and mind-mangling methamphetamine. It seems to me that to wait for people to find some kind of readiness on the street, it rarely happens before meth will drive them to meth-induced psychosis and fentanyl will kill them. And this is the problem we face now, I truly believe that fentanyl and meth change everything. They change everything we've ever thought about drugs on the street. Production, profit, smuggling, overdose treatment, addiction, it's on and on and on. It's just a remarkable transformation in a very short period of time. And if you wait for people to find some kind of readiness on the street, Meth will drive them mad, and fentanyl will kill them before that readiness is there. And this is the problem that we face, the county faces, but not just here and not just in Los Angeles, but all across the country. You're seeing the same thing. People say, no, I'm not ready. I don't want to. The problem is that was fine when heroin and when cocaine were on the street. But with fentanyl and meth, the ball game has so completely changed that, and I believe that's one reason why we are seeing record overdose deaths every year. It's because people are on the street too long, and what that phrase "too long" means is change, because it's fentanyl and meth out there now.
See, and I think Dr. Sy is talking about that directly. I think the discussions that we've had here in Los Angeles County is looking at how to engage people where they're at and not waiting for people to get to a place of readiness of change. As an organization, we've continued to modify what we do. We're still an abstinence-based organization. However, we look at it as a person with schizophrenia that starts experiencing symptoms of schizophrenia. We're not going to throw them out of treatment. We're going to get them the help that they need. And when people start looking at use of alcohol or other drugs as a symptom of the disease, instead of it being the disease, we can provide better treatment services. We can actually address some of these issues that we fail to address. I believe that drug Medi-Cal changed the whole game here in Los Angeles County and the state of California. In 2017, when Los Angeles County went to a drug Medi-Cal system, we opened the floodgates for treatment services for individuals. First time ever in Los Angeles County's history, we've been able to do that. I watched many, many years of people trying to get to treatment and sitting on a waiting list and dying. People have been dying in Los Angeles for a very long time of overdoses and other complications from drug and alcohol addiction. We've opened the floodgates, and we have failed to create a system that funnels people into services that need services. We don't have individuals out on the street trying to help people into treatment because we haven't figured out a way to fund that type of treatment yet. We've got a long way to go in looking at how we can engage folks who are not ready to be engaged in the traditional sense of engagement.
Isn't that why Governor Newsom, pushed for the care courts? I mean, and look what's happened.
That's just one system. We took when drug Medi-Cal started, we took court systems that were effective and working here in Los Angeles County and decimated those. We took a drug court program that was very effective. We had 140 individuals that were in an alumni program that was part of our drug court system, the oldest drug court program in Los Angeles County, that is closed today because there was the inability to determine medical necessity for individuals who were in jail and coming out in a drug court program. We couldn't figure out a way to do it. A system that was set up for someone to be in treatment for a year was no longer there. And that was the type of treatment that it required for those individuals who have been institutionalized the majority of their life to find recovery, was that flash incarceration. When something they were doing was not appropriate to that program, they did flash incarceration. We did a lot of treatment strategies that worked for that population and saw good results, but that stopped. And I'm not sure how we're going to replicate or be able to do the same kind of service with things like care court. We have to figure out how to engage people where they're at.
Well, but also part of the problem is we, like as a city, where our hands are tied. Unless a person on the street agrees to take, what we're offering, the services that we're offering, a lot of times we can't do anything about it because we're not, they're conservators. The state makes it very, very difficult for us to get that ability to help them. And so it is a very frustrating thing for us as you know, as local officials as well, because look, you know, both council member Nazarian and I we have small cities that we can walk in a couple of hours and we see the people on the streets, and yet we cannot help them because then we have civil rights issues happening and things like that. So it's a difficult situation for us as well. You know, on the side of getting people to take the services.
I would realize that it's a holistic approach, but even while we want to provide the services, if we have the services available, you can't force someone to take you up on that offer. So exactly what Councilmember Meister is saying, it's quite challenging for the position that
The
lawmakers.
ironic thing about all that is that's why people are dying. That's the compassionate approach supposedly, and that's exactly why people are dying on the streets. Given the fact, again, as I've said before a couple of times now, that the drugs on the street are methamphetamine and fentanyl, and not even crack anymore so much, and certainly not heroin as much. You know, it's a whole other game changer.
Dr. Sy, go ahead, please.
So I know that we probably can't have as deep of a discussion on this very important topic, but I did want to spend a couple minutes just to kind of address what's been said. I certainly acknowledge that it's challenging for everyone, whether you're, you know, a council member or whether you're a family member, in terms of what to do when people who need services clearly don't want them. I grew up with a mom with schizophrenia. She never had any awareness of her condition. We had decades of difficulty getting her into care. I've been a strong proponent of court-ordered outpatient treatment. In California, you know, different terms, assisted outpatient treatment, Laura's Law, there's different terms for it. One of the things that I think is important, given the focus of this meeting, is, you know, as a caregiver and family member, and as an addiction psychiatrist, there is a fundamental difference in terms of compelling people into psychiatric care and compelling people into substance use care. And I think as a society, that's something that we will need to think about carefully. Some of those key differences are, number one, prevalence. When you talk about the prevalence of substance use disorders, about 10% of people have a lifetime prevalence of substance use disorders, meaning 1 in 10 people potentially at some point in their life could be compelled into involuntary substance use care if we proceed with something like Senate Bill 43, right, which is the bill. So there's two main bills right now. There's Care Court, which is already law, and then there's Senate Bill 43, which is going through the process. That would redefine grave disability, right? So the prevalence is a key difference. The treatments are also different, right? Sure, we have some medications for substance use disorders, but not for the majority of substances, right? Primarily alcohol, sedatives, opioids. Some medications can be used off-label, for example, for methamphetamine, but they're not FDA approved. And so tools are different. And the question of how long does someone need to be in substance use treatment, particularly if the main tool you have is talk therapy counseling, right? If they don't want to be there. There is no golden number. And so I just wanted to highlight this issue because I think it's, we need to acknowledge the frustration. I mean, I went decades. It was the most painful period of my life with my mom. But we also need to think about how we do this thoughtfully, particularly for people with substance use disorders, because all of the inequities that we've focused on for many years now, they're inherent in the system, and they will show their face with major system transformations such as this. Care Court is more circumscribed because Care Court only focuses on individuals with psychosis and schizophrenia, right? So that, to me, that's different.
Wow, thank you for sharing that, Dr. Sy. Councilmember Meister, you had a.
Yes, I'm going to ask Sam. The Least of Us is your second book about the opioid epidemic, and I'm wondering what moved you to keep reporting on this topic 6 years after the success of your first book, Dreamland. And if you can tell us a little bit about your research really in writing.
Yeah, the first book, Dreamland, was about what's now classically known as the opioid epidemic, which is the promotion of narcotic prescription painkillers by drug companies that made them, to doctors insisting or urging doctors to use them far more aggressively, far more liberally, far more refills, and I think that was a big part of it as well. And that created a new population nationwide, because this happened nationwide, of opioid addicted Americans, and some subset of those folks went on to use heroin. And at that point, the Mexican trafficking world awakened to the new situation, the new market that we had essentially created by this overprescribing of prescription painkillers. I think I frankly thought at the time when I published Dreamland that there was no need for any other book, because I wasn't thinking old. I'm a crime reporter, and I was thinking old school, like what could be worse than heroin? I think I in fact said that to my publisher at one point early on. And then as I began the book awakened people. It was a remarkable experience for me, because when I was writing it, there was nobody knew how to pronounce the word naloxone, right? I mean, really, it was very hard to find. Parents didn't want to talk about their loved ones, or their family members didn't want to talk about their loved ones were addicted. The obituaries rarely told the truth about why the person died, very much like the early days of the AIDS epidemic, if you remember that. My book subtitle was Dreamland, the True Tale of America's Opiate Epidemic, because nobody outside of medicine knew what an opioid was. And I had to put that into the subtitle. There were three, when I wrote the book, when I published the book, there were 3 lawsuits against drug companies. And over the next 3 or 4 years, we watched at my house just in utter amazement, because we were never expecting this. As the book kind of created this new awareness, and people came out of the shadows into the light and telling their stories in all kinds of different ways. And you'd created a movement, one of the great grassroots movements of our time, in my opinion, although it's not viewed as such, because it had no press officer and no president and no union and all that kind of stuff. But it was people coming out of the shadows. They created a new movement that politicians begin to recognize. They begin to rethink budget priorities. They learn to pronounce the word naloxone. Obituaries begin to tell the real cause of death. And amazingly now too, I began to see hundreds and hundreds of lawsuits against the drug companies, and also some of them against the Sackler family, which owns Purdue, which made OxyContin. And along the way, as I began this was, I'm telling you this because we lived this in my household, and I began to get all these invitations to come speak. It's embarrassing. I mean, I'm kind of embarrassing. And between September of 2015 and February 2020, when COVID hit, I did 265 speeches, which is insane now that I think about it. It's just way too much speaking. But here's the thing. This was my Dreamland was my 3rd book. I'd written 2 books about Mexico, where I had lived for many years. And I love those books. Those books are fantastic books, in my opinion, and nobody read them. Okay. So when people all of a sudden are demanding or asking you to come speak, you're going to go, yes, I think I will, and so that is what kind of got me into this next phase. And as I was speaking over those years, I began to realize that I was seeing in real time what could be worse than heroin, and it's fentanyl. And then along the way, I also began to see methamphetamine, and the methamphetamine story is a fascinating one too, because the meth coming out of Mexico is so potent, is creating this kind of meth-induced psychosis all across this country. It's a very severe problem, and it's bedeviling counties and so on all across the country. But that is kind of why I began to, I didn't really expect to even write one book about this. And then the second one just kind of naturally followed. Now I think I may try to write about something entirely different. We'll see.
had said earlier that this is pretty much just coming from Mexico. So
Yes.
that this is not being produced in the US. This is
No, the meth made in Mexico has completely outcompeted the meth that we used to have, made by meth cooks, Breaking Bad and all that kind of stuff, right? You had meth, the Mexicans were making meth for a lot of years through the 90s with ephedrine, the drug that's in the Sudafed and all that stuff. But they couldn't get their hands on enough ephedrine to make more than enough to cover parts of the Western United States, like LA and other places, but didn't really cover the Western United States, and really didn't cover at all the Midwest or anything. And so that was taken up. What meth was circulated in those areas was made by famous meth cooks. You see this in Breaking Bad, but also in other movies and so on. All of those meth cooks have been run right out of business. They cannot in any way compete in terms of price and potency with the Mexican meth coming up now over the last 10 years. As I say, it's just the Mexicans have unbelievable access to ingredients, largely from China, through the shipping ports on the western side of Mexico, and they can make this meth cheaper and far more potent than anything some guy in Nebraska or in Oklahoma could ever make. And so all those meth cooks, as this meth from Mexico has essentially covered the country in the last 10 years, as I say, almost pretty much covering the entire country about the time that COVID hit. The local meth cooks just can't compete, and so you don't really. It's like what Walmart did to Main Street. That's kind of what Mexican meth did to the local domestic meth cooks that we used to have in the United States. Don't have them anymore.
That's really interesting. So it sounds like that the federal government has to step up in order to.
As does the Mexican government, by the way. I mean, I agree. We have these huge problems that surpass, and we're seeing this now in a lot of what we're talking about right here. They surpass any county, even a county as big as LA, but certainly smaller counties, surpass really any ability for counties to do much more than simply just kind of flail. And I feel for people at those levels, because the drugs are just too relentless, too potent, too immense in theirs. And so we have Mexico, where I lived for 10 years, wrote 2 books about that country, which has a severe problem with corruption and a kind of a debilitated criminal justice system, and needs to address it and doesn't seem to want to. And on this side, we have a absolute problem with the wanton sale of assault weapons. And that is a problem, because those assault weapons are then smuggled into Mexico, and they help guarantee the impunity with which those same traffickers make the catastrophic supplies of those 2 drugs and then smuggled them. No, so it's almost like we are arming the very people who are killing us and driving us mad. And it's an interesting fact that our a ban on commercial sale of assault weapons went from 94 to 2004. It ended during George Bush 2 and in 2004. I do not believe it is a coincidence that the cartel wars began the very next year. In 2005, really began to amp up, and then after that, of course, it was just it's been crazy. And so, but I do believe that is largely because they also had access to potent supply. In this case, it was potent supply of assault weapons smuggled in from the United States, where they were being sold quite easily. And of course, ever since 2000 and the end of that ban, we have seen, as we see with these ghastly shootings every couple of weeks, that they are so common that even 18-year-olds can have them.
Yeah. Is for the doctors here, is there a certain demographic of user that is more prevalent now? You know, have the demographics shifted in recent years?
Well, I would say that well, first, to tie this question into the one before, the severity of problems can feel totally overwhelming, and is often very overwhelming. I think that it's really important that we talk as we are about multimodal ways to help people with severe substance use disorders and mental health problems and homelessness, as Dr. Tsai was describing earlier. And at the same time, we have to be thinking upstream. We have to be thinking about prevention. We have to be thinking about the many people every single day that are beginning to use substances or beginning to use problematic. People don't go 0 to 60, overnight. And because these substances are so potent, it often feels like they do. But there are many, many points of intervention before somebody ends up in an unstable housing situation, and before they end up on the streets, and before they end up with further trauma exacerbating their situation. I think that the demographics haven't markedly changed. Mm-hmm. And substance use disorders cut across all demographics and all socioeconomic groups. Yeah. What we see is that if you are Black or brown, you have a harder time accessing treatment and accessing services. If you are poor, if you're disenfranchised, you have a harder time getting services, and so you tend to have more severe course of illness and worse consequences. But substance use disorders cuts across all demographics. What varies tends to be what people use, as you look at different demographic groups. And it's part of why we need to be thinking, as we think about problems like this, we really need to be thinking broadly about many, many different types of interventions at different parts of the whole continuum. And substance use disorders is like a big umbrella term. There's so many different flavors and types of problematic relationships that people have with substances. And we need to be thinking about alcohol, because alcohol we sometimes forget about as we talk about. Alcohol continues to be the major killer, and continues to create tons and tons of havoc. So lots of opportunity to intervene. I think we will get to that later in your questions. But I think some of those upstream opportunities offer a lot of hope as well.
Right. Well, thank you for that. I want us to talk a little bit about destigmatization, but before we get there, can any of you describe the difference between fentanyl that's used in the hospital setting versus what's really found on the streets, and how there's a difference between, well, I think we touched upon this a little bit about the older versions of meth and what's on the streets now. I think that Sam definitely touched on that. But can you guys speak to that a little bit? Well, we're interested in hearing what's being seen at the hospital level, like what is impacting ER services, if at all any.
Yeah, I can speak a little bit to that. So pharmaceutical grade fentanyl is typically what's used in hospitals, and it's typically used for pain relief as well as anesthesia. The fentanyl that's driving overdose deaths is not pharmaceutical grade fentanyl. It is what's being illicitly manufactured in garages, in clandestine labs by drug dealers, mixing chemicals, as Sam had mentioned, that they acquire. And the reason why it's so deadly is, in addition to the increased potency, which means that a very small amount can result in the stoppage of breathing or respiratory depression that then results in overdose from opioids, is also because it's being found in both illicit drugs as well as in counterfeit pills. And so, to the question earlier, I certainly agree with Dr. Danovich that the demographics of use haven't really changed. One of the aspects of overdose deaths that we are seeing is increased poisonings, where people are exposed to something that they didn't even know had fentanyl, and then dying. And that is happening tragically in some youth. Youth still represent a very small, less than 2% portion of all overdose deaths. So it's not the majority. The majority is middle-aged to older adults in terms of overdose deaths. But that is something that's new, right? Because in the past, we didn't see a lot of youth overdosing. There certainly was a lot of youth substance use, but they weren't necessarily overdosing because of the potency that we have now. So the hospital grade fentanyl is different, and they are contributing to overdose deaths very, very differently.
Right. So let's talk a little bit about some tools that we could share with some of our viewers right now. How does one know if they or a loved one has a substance use disorder, symptoms, changes in behavior, et cetera, that you could look out for?
Well, you said it right there, changes in behavior. And don't think that because they're only 10 or 11 years old, that those changes in behavior could not be related to substance use. I think that's one of the biggest issues or mistakes that parents make is their children, oh, they're too young. They couldn't be doing something like that. And they miss that opportunity that was mentioned a few times tonight about intervening early and trying to help someone early and not waiting until they're homeless on the street. I think that when you see changes in behavior, either sleep, mood, things of that nature, you need to check your children.
And what types of treatment are provided for those who have a meth or fentanyl addiction? Because there are a lot of options available. Can you speak to that, please?
Gary talked a little bit about talk therapy. We try and engage people in healthy living skills, teaching different coping skills, involving them in support groups. There's not a lot of medications that are available for methamphetamine addiction, but like I said earlier, about 95% of the people who come to us have underlying mental health disorders. So we're going to try and engage them in mental health services. The self-medication premise was mentioned earlier this evening. So we know that exists, that some folks need some assistance with mental health services. So we're going to look at all aspects. Health conditions that could be related to substance use disorders, dental, physical, other problems that could be part of use or could have contributed to use. Pain management is one of the ones that's very difficult to treat.
Right. So
just if I could chime in on that, and there's many different paths to recovery. One of the paths, certainly in the medical model, the first step is having an assessment. An assessment determines, is there a substance use disorder, which type, of which severity, is there a mental health problem, are there other physical health problems that need to be addressed, and where are those problems best addressed? Is it in the context of a therapist's office? Is it by going to 12-step meetings? Is it by having a primary care physician manage the condition? Or is this something that needs a higher level of care? And there are different levels of care: intensive outpatient, more intensive outpatient, there's residential treatment, there's different levels of residential treatment. One of the things, and in a way that actually gets pretty complicated, so that when you're an individual trying to get help for a loved one, it's very difficult to figure out how to navigate the treatment system and how to even get an assessment. So one of the things we in the treatment field have to do a better job at doing is helping people understand what the different levels of care are, so that you think about it just like if somebody has a heart attack, you know where you want them to go. Go to the emergency department and be admitted to the hospital. Do you need critical care? Different levels of care to address the problem versus going to see an outpatient cardiologist. So we need to be thinking about that way for substance use disorders. That way we can give the right level of treatment, to the right patient at the right time, and also use the many different interventions. There are psychotherapeutic interventions. There are many different specific psychotherapies that can be helpful for folks. Sometimes there's medications that can be helpful, particularly for opioid use disorder. There are life-saving medications that help with opioid use disorder. And so that is the approach I wish everybody could have.
And I guess you're also talking about the treatments that are available. Maybe the treatment providers also need to have a mental checklist of what may be appropriate for someone who is experiencing these issues. So what strategies or tips do you recommend to help minimize the potential of an overdose? We had talked about Nioxin or Narcan available, toolkits, training for schools. Can you please speak to that, of tools that we could actually help within our community to help both adults and our younger or more vulnerable members of the community?
Train everyone. It's when someone admits into any of our sites, that's one of the first things that we do with an individual is we orient them to the site. We go through patient's rights. That's for Gary. We do what's required of the state and county, but we also do training on naloxone. We teach people how to use naloxone. We don't expect for them to go back out and use drugs after leaving our facility, but the likelihood that they're going to be in an environment where someone might overdose is very, very high. So we try and expose them to naloxone training immediately. In our facilities, we have what we call Narcan boxes located throughout our facilities where an individual can grab Narcan and take it with them at any point in time. They don't have to come to us and say, can I please have some Narcan? It's available to them. It was something that we did, gosh, probably 4 years ago when we actually had to purchase Narcan ourselves. But we knew that we had to take a proactive approach to saving lives. And that was that at that point in time, that was the only proactive approach that was available. So we continue to do that. With the help of SAPSI, we've found other resources that have helped us obtain Narcan. So we're not paying for it out of our pocket, which has been helpful. Medi-Cal has provided as a benefit Narcan for individuals who qualify. But yeah, train, educate, and supply everyone that you can.
And I'm sorry, can you just, for those that may not know, can you please share what Narcan is?
Narcan is a reversal medication that is used through a nasal type of device. Typically with an overdose, it's going to take 2 to 4 sprays of a nasal device. And I know the doctors are going to do a much better job explaining the actual interaction that Narcan has or naloxone, but that's the basic premise is that it's used in case of an overdose. It's the best part about it is it can't create any harm to an individual who you use it on. So if somebody might be having another condition other than an overdose and you use Narcan on that individual, you're not going to create another complication. It's very harmless in what it does for someone who's not in overdose, but for someone who's in overdose, it brings them out of overdose, and it can bring them out of overdose extremely quickly and be a life-saving technique.
Right, and it's available now for many people. I don't know, Dr. Sai, if you want to speak about where locations are that it may be available.
Yeah, so I mean, people can get naloxone from their primary care provider. It's covered by your health insurance, and so you won't have to pay anything in general out of pocket. It can also be accessed in pharmacies. It does require pharmacies to have trained pharmacists, and so not every single pharmacy in Los Angeles County offers it without a prescriber's prescription, but many do. There are also community-based organizations, nonprofits that offer it, such as endoverdose.net. That's one of the groups that offers it. There are, mobile outreach teams that receive naloxone through a state grant that distribute it to people experiencing homelessness and other high-risk populations as well. So there are a lot of different ways that you could access naloxone. And one of the new things that's going to be available relatively shortly is over-the-counter naloxone. So it's just, sitting next to the over-the-counter medications that you can get at pharmacies. That will be a big change in terms of access.
Great. Thank you so much for that. Now, you mentioned something, Dr. Sai, you shared a personal experience that was very deep, and we appreciate that. So I wanted to talk about substance use stigmas that keep those that are addicted in fear and can prevent them from seeking help, both substance abuse and mental health. It can also prevent individuals from getting the full support that they deserve. I'd love to get the panel's views on how we can destigmatize drug abuse overall, and also getting the help that people really require, especially for a lot of minority communities that may be ambivalent to wanting to admit or talk about having a substance abuse issue.
Yeah, I can kick us off. I mean, I'm a big believer in the power of story. That's why I appreciate conversations with Sam. And I'm a big believer in personal story. That's one of the reasons why I share, my personal experiences. My mom didn't have any substance use disorder, but she did have schizophrenia. And, there are increasingly personal narratives that are shared by, could be high level government officials, could be, someone that you watch on TikTok. And so I think that that's really important in addressing stigma. I think that the language that we use is really important. People with substance use disorders, as opposed to, addicts, for example. I mean, there's little things that we can be doing to try to address it. But I think the most important thing in my mind is just communicating our personal stories, and having more people communicating that, because then it communicates that this is not something that's hiding under a rock or in the shadows. This is something that a very large portion of the US population, the global population, experience, and simply has been something that we haven't talked about, and it's far past time for us to be having open conversations about this, similar to how cancer. I mean, cancer was previously a stigmatized condition. People didn't want to talk about cancer, right? Whereas now, we got different colored ribbons all over the place, and I envision a day where that's true for all behavioral health conditions, but we have to talk about it.
Yeah, if I could just add to that. I think Gary's point about language is so important. We talk about people who suffer from substance use disorder as junkies, as people who have, when their urine is positive for a substance, we describe that as a dirty urine. When a person has diabetes and has sugar or glucose in their urine, we don't talk about that as a dirty urine. The language with which we talk about addiction tends to convey a moral perspective and exasperation, the exasperation that we feel when people have this, often mysterious condition where they cannot stop a behavior despite wanting to. I think that what our language can convey, and what's most important, is compassion. We need to get past the exasperation to find compassion for the incredible entrapment that people that are stuck using substances feel, and because they are almost always way harder on themselves than we could possibly be towards them. And it makes them incredibly sensitive to things that we may unintentionally say or convey as we talk to them about their use. So I think compassion is important, installation of hope, bringing hope to what we do, and really bringing an affirmative orientation to meeting people where they're at, whatever they're ready to address, and being resourceful and helping to supply them with tools and to eliminate barriers for them to pursue their own self-directed goals to live a healthier life.
As a person in long-term recovery, there's a lot of stigma related to individuals who are in recovery. For myself, I've learned that there's certain venues where you just don't share about your own personal recovery. And it's because of the judgment that gets put on the person who is in recovery. And Doctor, you explained it very well. There's certain drugs that people use that have a much higher stigma related to them. A person who has an alcohol use disorder is not going to be viewed the same as the person who has a heroin use disorder. And currently methamphetamine, same thing. What I have found for myself is that there's individuals who I'm going to be able to share my history with who will benefit from that sharing. And that's not always going to be in a panel like this, because the sharing of information that I like to use in a panel like this is what I've gained through my own personal education and the work that I've done through school and the work that I've done in this field, not my own personal recovery. So the term Alcoholics Anonymous, I think, spreads over into a lot of people's lives. They realized very early on, back in 1939, that you did not want to be identified as a person who was an alcoholic and to keep that secret. I still think that exists today. Dr.
Can I say something that actually I was able to kind of push back against what my esteemed colleagues have just said. My feeling is, as a journalist, that the only way as Gary Sy said, the only way people change their minds about a topic is through stories. And stories told many, many different ways, through relatives, in the newspaper, on TV, whatever it is. There's personal contact with people. I can tell you as a writer that I think, frankly, and I'll be extraordinarily immodest on this, I apologize in advance, but I think my book did more, Dreamland certainly did more to change stigma and awaken awareness about these problems than almost any single other event, frankly. I know that I lived it, so I'm not gonna, sounds immodest, but I'm gonna tell you that I think that's really what happened. And the reason that did happen, the reason that book had that impact was because I used very direct language. I still use the word addict. I don't believe it is at all stigmatizing. I believe it is actually a very concise term that gets across and allows you to tell very powerful stories in a very powerful way. And so I do believe that there's an incredible amount of stigma that goes along with addiction. And I do believe that the idea that people should be anonymous, Narcotics Anonymous, Alcoholics Anonymous, I think that we need to be talking about this in a very normal, common way, as Gary Sy said, with regard to similar to what we do with cancer. Now, I do not see much difference. It's that easy to say that most human beings have a risk of addiction as for cancer. I do believe that you cannot tell powerful stories with diluted language. So a person with substance use disorder or suffering from, so you're talking about 6 or 8 words when 1 word would do. I can tell you as a writer that does not work. That does not allow you to tell the stories that are really the way people change their minds. Stories are told with direct, concise language. Now, it can be told, you can use that word in a variety of ways, very negatively, disparagingly, insultingly, very honorably, or just neutrally. It doesn't matter. But my feeling is that this attempt to craft a language in which we don't stigmatize people is failing because it's not allowing for the kinds of stories that really will change stigma, and so that was absolutely the case with Dreamland, in my opinion. The reason it had the impact it did was because it told powerful stories with powerful language, and so to me, I feel I try to push back on anytime I can on this. I use the word addict all the time, and I think that there's a power in that. There's a normality in that. As soon as we start changing the language so that everyone's tiptoeing around it, all of a sudden it creates the stigma that we want to avoid. Mm-hmm. If people can just speak bluntly about things, matter of factly, about these things. And I find most addicts do. They use that term all the time. I'm happy. I use it as a writer. I do not believe that I can use the phrase a person who suffers from substance use disorder, 8 words. 8 words where 1 2-syllable word was, you cannot tell a good story. You cannot tell the powerful story. And it's that I'm trying to do. I'm trying to talk to people who have never thought about this topic. It's a general audience. It's not folks in the addiction field. I get lots of pushback on that. Fine. I'm used to it. I don't mind it. I understand that everybody has good intentions, and I understand the profound and beautiful intentions behind trying to change it. I just don't think that works, and it doesn't work in the most profound way, which is when you're trying to tell a story. You use bloated language. You use wordy. I would love it if they came up with a word shorter than the word addict. Then I'd use it. But if you're going to tell me I have to use an 8-word phrase instead of 1 word, I'm going to tell you that you are crippling the very way that people change their attitudes towards something, and that is through storytelling.
And I would wonder
if I could just make one response to that. Sam, I mean, I think it's such an important delineation that you make around who the audience is. And, thank goodness for your effectiveness as a writer and the stories that you tell and your capacity to reach an audience. I think when you're hearing from me and from Gary as clinicians, we're often oriented to how you talk to somebody who is suffering. And I've talked to people who are suffering to ask them, how do they want to be referred? And so I think that how we reach people, I think my main point is that we want to signal with our communication compassion, especially if we're trying to encourage people to get care, and we want to reach people upstream before they have severe disorders. And the language does matter a lot, especially when you catch somebody early on. Their conceptualization of what it means to be a quote unquote addict has a lot to do with whether they're willing to engage in support around it. So I think, thinking about different stories and different messaging for different groups is really, really critical, and then being effective in each of those lanes.
That's great. I did have one question for you though, Doctor, and this is something that has occurred to me for a while. Why do we refer to it as, a heroin use disorder? To me, our brains have evolved. It's a perfectly orderly way in which we react to using a drug as potent as heroin. It's not a disorder. It's actually the way our brains have actually evolved. And how does what manifests itself with euphoria and then cravings and the whole symptoms of addiction? I've always wondered why people call it a disorder, when in fact it seems to me to be the natural progression of our brain. That's how our brains are affected when we use this thing called like heroin, for example.
Yeah, it is such a mystery. I'll tell you, even for heroin, recognizing how addictive it is, and this is striking, only about 20% of people who use an illicit opioid like heroin go on to develop a substance use disorder. The majority of people don't. People try these substances and they pull out, they stop for whatever reasons. So not everybody who uses alcohol, which is broadly available, goes on to develop an alcohol use disorder. So it's not the addictiveness of the substance, it's an interaction between that substance and particular vulnerabilities. And we think of those vulnerabilities as the disorder. And then we've struggled with our language. We are now using disorder to get away from the term abuse, which we had before, and we've had our language has evolved over and over again to reflect our understanding. But that's why we call it disorder. And then lastly, we don't use addict because we don't want to define a person by their condition. And when Gary spoke about his mom, people used to refer to people with schizophrenia as schizophrenics, which is also stigmatizing. And so thinking about a person who's struggling with something as opposed to defining it by the disorder from a patient, or clinician orientation is the reason we use that often convoluted and heavy and indirect language.
But can I ask you then, why when you use a word like addict, say, or schizophrenic or alcoholic, does that imply that that's all that person is? You don't use the word migrant. or veteran and suggest that person is only somebody who has fought in a war, or that person is only someone who crosses borders. I have never thought, it was brought up to me, and I confess, I was like, I never thought of a person who's addicted to X as that's defines that person. That person has many different aspects to his or her life. Poet, truck driver, garbage and actor, whatever. There's all kinds of things that person can be. I just never have understood how we're supposed to believe that when you call, when someone is termed an addict or a diabetic, say that is all, that's just that's defining that person. You don't do that with any other words. And I don't believe that it's actually in the common way of using it. People are thinking, yep, that's all that person is, you know?
Yeah, Sam, I hear what you're saying, and I think we probably should move on soon. But I do want to just highlight, I understand the point that you're making, which is that societies attribute certain positive or negative things to words, all right? And those are attributions. There is no power in words in and of themselves, right? But I think the issue that we're highlighting is that when we talk about, when we use terminology around addiction, it's never in a vacuum, and there are always other considerations that influence that. So, I mean, the bottom line is, I know that you and obviously everyone here cares about this issue. You know, it wasn't intended to be a direct criticism. It is intended just to highlight that, I would say, particularly in the field of addiction, and I think that, you know, the dirty urine is probably the best example in my mind, right? Because you don't get any more positive or negative than that. It's pretty black and white. And so I think that's the main point that I was trying to make.
Thanks very much. And I really appreciate the conversation on this. It can be very contentious, and I really appreciate that it's calm and well-reasoned. Thank you.
So
we have a lot of comments in the questions and answers in the question portion of people saying they appreciate it. So I guess it really boils down to what resonates best with the person experiencing this, and how we can best use that language to make a positive impact.
you know what they always say, know your audience, Sam.
Right.
So
I really like the last comment that was made in regards to autism.
Yes.
So that's an interesting comment.
It's in the chat.
Yeah, it's in our question and answers. I find it interesting that individuals that suffer from having a mental health disorder have been able to get a support group of family members, such as NAMI, that has been very successful. And those of us who have worked in the treatment field for many, many years have tried to do the same for addicts in recovery and haven't been able to do it. Have not been able to get a group of families together that would support their loved ones, advocate, and develop policies that were for people in recovery. And even I think Los Angeles County took a run at it a few years back, where they were actually trying to develop their own policy group of family members, and unsuccessfully, I don't think it was able to manifest itself. But NAMI has done very well. That's the stigma that drug and alcohol addiction carries with it.
So I'm going to move to another contentious topic, and that is, and Sam, I saw you talk about this in a video I watched. Is the housing first model the right strategy for serving people experiencing homelessness who might have a meth or other serious drug substance abuse issue? And if not, it's a better alternative. Anyone want to jump in there?
I'll jump in. Yeah, thanks for that question. It's a good question. Sam and I have talked about this a little bit. You know, there's no question that housing first works broadly. There's evidence to support that. I personally support housing first. I think the question is, does it make sense to put all of our housing chips in the housing first bucket? There are currently, federal requirements, for example, that federal funds be used for housing first. In a county like Los Angeles, where homelessness obviously is it's a big issue, we do not offer a lot of recovery-oriented housing options, either in interim housing or permanent supportive housing for people with substance use disorders who prefer it. And there are, I know this because I've spoken with them, a fair number of people who are in recovery who would prefer a recovery-oriented housing option, whether it's interim or permanent supportive, versus a housing first option. So in my mind, I think that there's a space and a need for recovery-oriented housing. It needs to be apportioned, even if it's 5% or less, right? To demonstrate the need, and then to gauge, what the right proportion of housing should look like. I think that that's an important conversation, both from a policy perspective as well as from a financial perspective, because we all know there isn't enough money in the world to build the housing necessarily that we need in all the cities, LA, New York, et cetera, that we need them. And so we do need to think about this as a fixed commodity, but to be thoughtful about it.
So that's the third time that question has come up in my life today. I spent the morning in one of our residential sites today. I had the opportunity to meet with one of the health deputies in one of our residential sites today. One of the participants, we call people participants, they're patients. We call them participants. One of the participants came up and said, Bruce, I need a job and I need a place to live. 65-year-old African-American male who this is not his first treatment attempt. And he knows if he goes back out on the streets, the likelihood that he'll use drugs and alcohol again is very, very high. So he talked to me about that. The health deputy asked me the same exact question. What do you think of the housing first model? I think we need to find good supportive housing for individuals who are in recovery, not in recovery, individuals who are experiencing homelessness. We need to find a variety of different housing that's appropriate for the level of care that individual needs. I liked what Dr. Danovich talked about as far as assessing people and finding out what their needs are. I don't think there's the housing first model. One of the problems I have with the housing first model is there was very little fluctuation in what was going to be done in the housing first model. It was very prescriptive about what would be offered, and it wasn't very expansive. I think the fact of the matter that they did not make some kind of treatment opportunities available immediately when people went into a housing first model was a huge mistake. And I was told that they did. I was told, but the substance abuse treatment providers were not involved in that process. It was mostly other providers whose focus was not on substance abuse treatment or treatment for addicts who needed help. Sam, I'm going to try and be a little more blanket statements about this stuff. It wasn't there. So I think we need to figure out how we modify that housing first model. I know that a lot of it is tied to policy, federal policy, but there's got to be a better way that we do it. Gary has done a great job in finding dollars for us to have recovery bridge housing in Los Angeles County, which has been a great benefit for the individuals that we work with. And I'm hopeful that there is going to be more. I really hope there's going to be more. We have 450 people in treatment right now today. Some are in residential, some are in outpatient, but they're in treatment today. They need housing.
Can I say one thing about, I think these are great responses and I love it. I'd love to hear them. I would say this, that the housing first model seems to bring with it, and I'll try to find a charitable word for what I'm going to say, but a rigidity of response, which is to say that once this is in place, nobody wants to talk about anything else. And certainly not a modifying, as Bruce was just saying, kind of gradations, as Gary was saying, gradations of housing that recognize drug addiction on the street and all that stuff, and a major part of homelessness there is an almost inquisitorial, dogmatic silence imposed on people. When I was doing Dreamland, I was talking to people about this, and over the phone with 2 treatment providers in the Skid Row area on the same day, and each of the 5, the two of them lowered their voice when they were talking to me, as if they were talking about national secrets, or they didn't want to be pilloried, they didn't want to be, strung up. And I think that the housing first model has some benefits. But one of the deep negatives, it seems to me, is it seems to squelch all other discussion that might lead to other solutions that people who are simply true believers in the idea of housing first cannot and won't listen to or tolerate to be talked about. And I think that is a very, very scary and also completely counterproductive approach to any of this, because as Gary said, and as Bruce just said, it seems to me that there needs to be a wide variety of housing, and that at the end, for a lot of those folks, permanent supportive housing is a great idea. It's not such a great idea when you take someone right off the street and put them into permanent supportive housing with a meth-induced psychosis and who knows what else. It doesn't seem to me to be very effective. So that's what I would say about that.
The loopholes that people, the hoops that people jump through in order to gain housing in Los Angeles, especially in the Skid Row community, is astronomical.
Yeah,
I've had the opportunity to sit down and talk to some of those folks, and just the expectation of getting over to an appointment that's on the other side of town when this is an unhoused person. They have no transportation. Some of those expectations are just wrong. One of the other pieces that, because of the venue that we're in tonight, I just wanted to bring up this one topic, and that is, with nicotine addiction, we talk about the need for 10 quit attempts before someone is able to stop smoking on average. I don't know of any studies that have ever measured how many quit attempts does it take for someone to stop using heroin, methamphetamine, alcohol, or anything like that. And I really think it's something that we need to look at and try and figure out, because when DMC ODS first started, there was going to be a limit on how many treatment episodes someone could have. And I know we've taken that away, but I still would like to kind of get a better idea of how many quit attempts does it take to get someone to a place where they're going to stop using drugs or alcohol, or modify their use of drugs and alcohol to where it's not impacting their life.
The problem is that there's a stigmatization for the facilities also. If that number goes up, then they are seen as less effective. And so
why do you think I bring that up right now?
Right.
Thank you for recognizing that. Yeah, it's part of why I bring that up now. We're going to be measured on our effectiveness, but no one has ever measured what is an effective number of treatment strategies to get a person ready or able or to a place of where they're not using drugs and alcohol that's impacting their life.
Exactly.
And to that, Bruce, obviously we are focused a lot more on metrics now than ever. I will always push back and try to avoid defining quality for substance use treatment as in numbers with respect to episodes, or the problem is everyone's different, right? And so I think to the extent that we can, we're going to be looking for metrics that can respect the variability in people. And for everyone on the line, why this is so important is because right now in California and Medi-Cal, we're undergoing behavioral health payment reform, right? And part of that means moving towards value-based reimbursement, which is defining via quality benchmarks what quality is, and then basing certain payments off that. And so this is a really relevant conversation, really important topic.
Well, maybe we have to have another panel. I hope you'll all come back.
Thank you, Dr. Sy.
We are at 7:31, so I would say that we need to close our panel, but I want to tell you how much I appreciate our panelists, my co-moderator, and our viewers for participating in this really valuable discussion. We know that this issue knows no border, and it's affecting every part of this country, state, region. It's affecting us locally. It's so important for us to continue this dialogue so we can find ways to collaborate on this issue and make people aware of the risks of these drugs and how we can support our community members in terms of prevention and on the treatment side. In the city of West Hollywood, we contract with several agencies to provide programming and services, and as does the city of Beverly Hills. So what we're going to do is we're going to reach out via email to everyone that registered, and we're going to send them a listing of all the resources that we know of to all of you. So I would say to all of our panelists, if you want to provide those resources, how our viewers can contact you, that would be great, and we will send out that email. And we are also going to again, this panel has been recorded, and so we will be putting this on our YouTube, and we hope that you will share it far and wide so that we can get the word out on this issue. And I think, as you all said, the more we talk about it, to Sam's point, then maybe addiction is not it doesn't mean a stigma. And again, we need to be sensitive to who we're talking to in what venue, right? And so we all have a different audience that we talk to as council members, as doctors, as providers, and as journalists. So I think I learned a lot. I hope that you all enjoyed the panel. And again, I thank you so much for participating. Councilmember Nazarian, do you?
Yes, no, I echo the same sentiment. This was great. We really appreciate everyone, both on the panel and also for everyone who tuned in. I think that this is an important topic. It needs continued dialogue in order to be able to learn from one another and really grow, and to really be able to provide the services. This is something that is all encompassing. We need to provide services that are all encompassing, whether it's mental health care, addiction treatment, or whatever terminology works best to assist with where you want to be with that. And also, I think it even goes further, whether it's with transportation or with finding housing or helping someone find a job, because all of these things kind of work hand in hand to be able to provide the services that one person needs to really heal, get better, and be able to get back into society. And I'm very grateful for being a part of this, and thank you all for your candor and for sharing your wisdom with us.
Yes, thank you all.
Thank you very much.
Thank you
Wonderful
for
talk.
inviting
Thanks
us.
very much.
Thanks, everyone.
Bye-bye.